So welcome to the Population Health Collaborative Winter Meeting. I'm Krista Martinez with Constellation Consulting, and you're the convener for the collaborative. Also here from Constellation Consulting is Suzanne Lawson. I think most of you know her. She will be assisting us today. The Population Health Collaborative is funded by the New Mexico Department of Health, Heart, Disease, and Stroke Prevention Program. Please note that this meeting is being recorded. So I'm just going to recap. Attendees' cameras and microphones are activated today. However, we do ask that you keep your microphones muted. If you need assistance during this session, please enter into the general chat or message Suzanne or me directly, and we'll be happy to help you. As we begin today, we will not be doing live introductions, but please feel free to enter your name, role, and organization in the chat to introduce yourself. Following today's presentations, we will have time for Q&A. You may ask your questions live or post your questions in the chat window. Also, if you would like to make sure that you are added to the collaborative email list, please enter your email address in the chat window or email us directly at info@constellationnm.com. We're pleased to offer continuing education units for community health workers and health education specialists for today's session. At the end of today's session, we will post a link to our session evaluation and CEU request. If you are attending today's session by phone only, please stay on the call at the end of the session so that we can confirm your contact information and CEU request. So with that, go ahead and get started a little early. So we are pleased to have Dr. Arthur Kaufman, Vice President for Community Health at the University of New Mexico Health Sciences Center. You can read his complete bio at nmhealthequity.org/PHC. So with that, we'd like to turn the time over to Dr. Kaufman. We're going to give us just a moment. We're going to put his slides up.
Well, thank you very much, Suzanne. So this is such an important topic, and it's just all over the country, growing rapidly, well-funded. I can tell you that about 7 or 8 years ago, we got a grant to put together a website and a toolkit for social determinants, and the Commonwealth Fund funded this. But before we got to work on it, they said, just one thing, could you just not use that word social determinants? We have a conservative board, and they'll think it means socialism. This is how rapidly society has changed, where this is totally acceptable. We can talk about social determinants. And what I'd like to do is kind of run through some slides that represent a lot of what our work is at the University of New Mexico and around the state, and why this is so important at this time. Next. You know, this has been a debate going back a long time. In the middle 1800s, Rudolf Virchow, the great pathologist, had this idea that the main cause of ill health was poverty. This is in Europe. And he fought to make sure if he was going to improve health, he had to improve better schooling, better housing, all of that. It wasn't that popular at the time. Back in the early 1900s, 1910, Abraham Flexner on the right came up with his study, and he made health service delivery, the work of doctors, medical education, scientific. And it became very biomedical, and it vastly improved the quality of health services, because then they had to be linked, medical schools linked to universities to ensure that they were scientific. The problem was they closed about 2/3 of all the medical schools that were proprietary. They were not as good scientifically, but that meant closing virtually all the women's medical colleges, virtually all but 2 of the Black medical colleges. And it became a very white, privileged class of people who became doctors. Next. So here's a data fragment from New Mexico that speaks volumes. If you look at the endpoint of deaths from diabetes, and you look at the quality of care for diabetes in New Mexico, as it turns out, the one population who gets some of the best screening and treatment is the Native American population. Federal grants, state Department of Health, their local health departments on reservations, really quite extraordinary. It's really a model. The problem is that the outcomes are the worst. Best screening and treatment, worst outcomes. As a matter of fact, if you look at reservations today, most of them have dialysis units because of the impact of diabetes on kidney function. Well, the reason that this high quality care does not translate into very high quality outcomes is because that care cannot make up for decades of poor educational outcome, low income, low high level of social marginalization, racism, all of the social determinants that have far more to do with health than healthcare delivery. Next. So if you look at the Institute for Public Health, they did a study and they tried to stack up every single state and measure them on the basis of how much high quality social resources to address social determinants they had. And if you were at the bottom of this list, you had the least, and you had the highest level of adverse social determinants that were not being addressed. So you can see New Mexico is at the bottom, and it explains why in trying to improve the health of New Mexico, it's very hard if you're going to focus on the healthcare system and not address social determinants. And this is really made even more dramatic in the next slide. So if you look at the bottom two figures, about 90% of our healthcare system, of our US healthcare dollar, goes into the medical care healthcare system, which affects only about 10% of mortality. But if you look at the social determinants, and they would be found in the lifestyles and environment over on the right side, we put about 3% of our US healthcare budget into social determinants. This is not the pattern of the other Western countries. They have much more of a balance between social investments and medical service investments. We are way out of proportion. And for that reason, that's why we spend the most, but we have the worst health outcomes. Next. So we decided we're going to study this, and we're going to find out in our own primary care population at the University of New Mexico and at our partner organization, the Federally Qualified Health Center First Choice. And so we asked about 50,000 patients, just kind of basic social determinant questions. There are more, there are about 12 of them. These are just examples. And we published the results of the first 3,000. Next. And what we found out is about half our primary care patients have at least one adverse social determinant led by utilities, income, employment, education, housing. And half of those have more than one, some 5 or 6. The problem was it's totally unknown to the clinics because we don't ask these questions. And yet we know the profound effect answers to these questions have on explaining our patients' health. Next. Well, as it turns out, this is not unknown to health providers. Robert Wood Johnson, about a decade ago, they did a study of, I think it's about 1,000 physicians across the country, and they asked them about what is the balance between these social needs and medical needs, and they found that 80% of them said that they're equally important, and that not only that, their healthcare system doesn't give them any support to address social problems. And if you address social problems or you don't address them, the care will be worse, health outcomes will be worse, but also that it's not just poor people, it's all patients to a certain degree. Next. So with this data, we worked with the university hospital, and they agreed to put community health workers, community support workers in every primary care clinic. And we would ask our patients these social determinant questions, but then we had ethically a way to address the answers for those who wanted help. As it turned out, about half our patients had an adverse social determinant. About half of them said they wanted help. And that made a big difference. Next slide. Next. This actually is, and next slide as well. This is mostly our data, but also some of the other data. And it shows if you do this, if you intervene, you screen this population, you'll get a substantial reduction in hospital expenditures, health expenditures, about a third fewer hospital admissions, a big drop in ER visits. And this is a very conservative. We thought it was about 4 to 1. It's about $2.50 to every dollar spent on hiring and training and deploying a community health worker. Next. Now, what was interesting is state Medicaid picked up on this, and they were looking at other data as well, not just from UNM, and they realized that this is a powerful way to screen and treat those very vulnerable Medicaid populations. And so they required every Medicaid managed care organization that they funded had to put money into community health workers. And they worked in the communities, they worked in clinics, they worked in the offices of the managed care organizations, intervening in those patients. The problem was, not the problem, but the limitation was that they tended to focus on those of highest need, those who were repeatedly admitted to the ER, hospitalized, things that were very preventable. They focused on that small group. But remember, our data showed that half the population has at least one adverse social determinant. So what they were missing was the ability to prevent, to intervene early and prevent those from becoming level 2s or level 3s. So that's been a big push for ours, to look at if we can't make a broader intervention for the whole population, not just for those who hit the ERs or be admitted frequently. Next. Well, a big policy change is helping us accelerate this work within the healthcare system. This year, and I think it's Krista Martinez, she and I worked on this big project funded by CMS federally, and there were 32 comprehensive sites around the country that tested this question. If you screen large numbers of Medicare and Medicaid patients for social determinants, and you intervene in those who had high needs, could you demonstrate improved quality and decreased costs? Very much like the study we had done. Presbyterian was the recipient. We were their partner in this, and then we work with partner FQHCs and others in Bernalillo County. And we had to screen 75,000 Medicare Medicaid patients every year for 5 years. And the outcomes were positive. Yes, we did that. We showed that the data. So CMS this year came out with this requirement. In this year, 2023, all adult inpatients in all the hospitals in the United States must screen for the 5 major social determinants: housing, food, transportation, utilities, and safety, all of them. And we know that after this year, it's going to come down and say, now do something about it. Well, we've been doing this for a long time. So our Office of Community Health and the primary care clinics, and the hospital are kind of fashioning a program to really work on this, to screen everybody and be able to intervene, because we have the ability now with our community support workers. Next. We know that there has to be a better way of being alerted to the fact that our patients have an adverse social determinant. When you see a patient, we have the first page, we have the name, we have the vital signs, weight, oxygen, blood pressure, pulse, respiration, we have all of that stuff. And we look at it very quickly and we say, oh my God, the pressure is still high. I got to do something about it. What are we going to do with social determinants? People are not used to looking at this. So we're coming up with different ways of, this is just one of the ways of portraying this. You know, when you drive down the street and you're driving and you're in a 35-mile zone and it says a little sign says 35 miles and you're 42, you don't put on the brake, you just keep going. But when you see that sign that has those flashing lights, you hit the brake immediately, it alerts you, it changes your behavior. So we're coming up with ways of doing this where everyone, when you see a patient, oh my goodness, look at this. They have, they have a legal problem that's been taken care of. But they still don't have transportation. In other words, that's the way we want to have everyone look at this. Next. So we have two kinds of newer health workers that help us with social determinants. Both of these are experts in social determinants, and they come from the communities served. The one I mentioned were community health workers. In the hospital, they're hired as community support workers. The other are health extension agents, totally stolen from an agricultural model. Every county has agricultural extension agents, and they link the land grant universities resources to the front line through their extension agents. So we love this idea. So we're putting health extension agents all around the state, and they work not so much with individuals, but they work with organizations to change policies, to work on the fact that, wait a minute, we need to have better education programs. People need money in their pocket. We're trying to get transportation up in a rural town. So they work more on the policies, organizations, and the social determinants themselves, less with individuals. So those two become very strong partners addressing social determinants. Next. Our goal is that we'll have health extension in every county. We have community health workers almost in every county, but we're moving in this direction. Next. One of the other strategies we're using to kind of change the culture is we got funding from United Health to create a certificate of public health. And we're not talking about the whole curriculum. I mean, of course, we're not talking about 14, this may be 4 or 5 hours, and it'll be modular. So you could work on just a couple modules that are relevant to your work. But because of this huge change in demand now that all hospitals, for example, are participating, we're going to go ahead and try to train our whole healthcare system, because everyone has a role to play in this, all the way from medical assistants to nurses to inpatient, certified nurse assistants, social workers, community health workers. Are going to put them on the wards, physicians, residents, students, so that the whole system has to change really to embrace this. So that's another step we're taking. And we realize that, you know, main campus, law school, they have a lot to say about social determinants on there. So we're going to involve them as well. Next. Some people to get kind of jazzed up about why all these social determinants have such an impact on health. These are just a couple of examples. The data shows that if you graduated every student in the United States from high school, you save as many lives as every smoker quitting smoking. And I know that there are groups out, maybe all of you work in the cardiovascular space, that a large percentage of deaths from cardiovascular disease for men and women are attributable to lack of a high school education. So you have smoking, you have education. Those are huge impacts on health. So as a health system that is looking at what causes the illnesses we see, we have to get engaged upstream. Next. This is just an example. We're approached by groups in the Navajo Reservation. They're concerned about a very high turnover of doctors that come and go in the Indian Health Service. Couldn't they train their own? And so we put some effort into getting more kids to graduate from school from the Navajo communities and become interested in enter any of the health careers so that the retention be much higher. And next slide. There's more data about that. That's interesting. We, the medical school, in order to get a more balanced medical school class that represented the geographic and ethnic diversity of the state, put together this BAMD program that's really successful. They do talent searches all over the state, and they get high school students who are interested in medicine, and they'll guarantee them admission to medical school. This is to pass courses in college, and they can go right to medical school in UNM. And the kids they take, 2/3 of them are from rural New Mexico, 2/3 are ethnic minority. And that has changed the makeup of the medical school class, which now very much reflects the distribution of the state. Next. This is another less understood outcome or slide. And what it shows is that if you are an African-American or Hispanic physician, I'm sure it's the same as if you're a Native American physician, your likelihood of seeing patients of that ethnicity is about 5 times as high. Recent data shows if you are the same ethnicity, the quality of your care and the outcome is better. We did not describe why, it's better. The other is that we focus in the United States a lot on disparities on the basis of ethnic differences, but the other is economic differences. And as it turns out, the income of the families of medical students every year is going up and up and up, becoming more and more disparate from the income of the patients they're going to be seeing. And that has an impact on what careers physicians choose, where they choose to practice, what their expectations of income are. So these are looking at who you're taking into health professions is a profound difference. Next. There is also, we tend to think, especially when we get more this provider happens to be physicians, but the studies show that if you can get a physician to work in a rural area, they generate about 17, 18 people they hire directly or indirectly, and they generate $1 million in business for that community. They keep the hospitals open, they keep the pharmacies going, they order home health care, they help the business of the community. So we tend to think of getting docs in underserved areas in general as increasing access to providers. Absolutely right. What we don't talk about is raising the tax base of a community and therefore having its economic impact on health by those indirect means. Next. We did a project which really raised the issue of loneliness, especially among elderly. And as you know, there's lots of national data now showing that for the first time, we're actually living less, we're dying earlier. Diseases of despair, alcoholism, drug addiction, overdoses, suicide, all of those are rising rapidly, and underlying a lot of that is simply loneliness. Next slide. We were given a request by the Aging and Long-Term Services Department, and basically they had 18,000 seniors who had called for services that they deserved, but they didn't get any return calls. And the reason was Aging and Long-Term Services did not have enough staff to call them back, and they asked, could we help? And so our group mobilized about 86 volunteers. Most of them were nursing students, medical students, staff, others who volunteered. And the Aging Long-Term Services gave these long list of seniors all over the state. And they got, I think it was about 12,000 of them. They called them and got them services. But what's interesting, they wrote notes on the side. Not only did they give them specific services like walkers and appointments and other things, they found the loneliness was profound. And people needed to talk and they needed to have social connection. So another major social determinant that we don't ask enough questions about. Next. This same idea of a call center, which is able to reach thousands, was used during the height of the pandemic when we were asked, could we call the quote special population to try to get them vaccines? What this meant are people who don't have the internet, or they didn't have transportation to the vaccine sites, or they didn't speak English, or they didn't understand how to use the equipment they did have, or they were frightened. So given the list of all those people who requested service but didn't know how to get them, they did all of it. In other words, and I think this is about 8,000. They got them, again, all over the state by phone. They made appointments. They even got fire rescue to go to some of the homes of elderlies who couldn't leave and give them vaccines there. So it was quite profound. It's another way of thinking through how do you give services when people have nothing but a phone, or they're so remote they can't get in to a regular center. Next. Yeah, this just shows these vaccines were given all over the state. Next. What we learned is not just theoretical, we actually called upon others at the university. We were struck by the expertise across the whole campus. There was some, I forgot who came up with this definition of a university. University, they said, is a set of colleges linked together by a common heating system. And it talked about how siloed everything is in universities. And we have the Gulf of Loomis, we don't cross the street very much. But what we found when you talked about social determinants, it was almost a common language. You could get all kinds of resources that you didn't even know you had and expertise from other colleges. These are just a list of them on the left. Next slide. So here's an example. We got a request from veterans living down in Silver City that it took them, God, almost 20 hours to make an appointment and go up to Albuquerque and come back. Because it was like a milk run. They had to, a little VA van would pick them up and go to every small town in the south and southwest to go to Albuquerque. And then they had to sit and wait till the last person was seen at the VA hospital, get it back on the bus and come all the way back. So they said, is there any other way? I said, we didn't know, but someone pointed us to the College of Engineering in their civil engineering unit, and they have expertise there on transportation. So they designed a whole system, and we're still working on this now, but you can get these small cutaway units and you can deliver passengers, but you can also deliver freight. You can bring medications to elderly people's homes. These vans can run around locally all the time, and then they can make long trips, let's say from Silver City to Albuquerque. A whole new way of thinking about this major social determinant, especially in rural New Mexico. There are ideas out there that we could support. Next. There's major problems. There are two counties that have the highest rates of food insecurity. One is in the northwest in San Juan County. And we got a grant for one of our health extension agents to coordinate and develop a food hub. And she worked with local farmers. They got refrigeration for perishables, and that has just grown. The other very high need area is Luna County on the border. That's where Deming is. And for that county, their priority issue is transportation, which we're working on. Next. The law school asked us to help with this problem. The clinical law program, all those students who do these clinical practices as part of their education had all been learning about earned income tax credits. And that meant they could work with clients, and if they were indigent, they didn't make much income, had low income, as long as they are have a social security number and work at least 1 hour a year. Those are the two criteria. And then if you have more children, each of those you can apply for earned income tax credits, which even if you never pay taxes, you're eligible for. And many people just don't know they have access or eligibility for this. And so they were working with us, and all their students became very proficient law students in doing this. The problem was, how do you scale this up to hundreds of thousands? And so the approach is to say, suppose we could train community health workers with all of their clients and then do this all over the state. So we were fascinated. I'd never heard of this. And this is incredible because we weren't as sure when someone has low income, what can we do to help them with income? We could say, we'll get a better job. But here's something you can actually, and you're giving people, $4,000, $5,000, $6,000 in their pocket. That keeps them in their home. They're not getting their car repossessed. They're sending their kids to school with new shoes and food. I mean, it's quite extraordinary what you can do with this amount of money. And this money is used quickly in the local community, so it helps the local economy. So we took this on, we trained our community health workers, and then we also we got a large federal grant to train large numbers, and we're in the middle of doing that now. I'm amazed at the amount of money we're from this program moving into people's pockets. It's quite extraordinary. I think that's the last. Next. Yeah, this is the last one. So this is what I see as our challenge. Most health systems want to see a quick return on investment. And so they focus on intensive care, all the resources, social determinants, all of that for a small number of people, way on the right side. We know that you have to move leftward. You have to include a much larger number of people in a practice or in a hospital setting that have all those risks that you can nip in the bud. You can get them transferred, get them utilities, all of those things that makes them whole. And then you have to do a bigger job for making sure resources are available in the community at large for the whole population. And if you can look at those three as intertwined, they relate to each other. You can't just focus on one if you're serious about the health of the population. So that is our current focus. Thank you.
Excellent. Wow. Dr. Kaufman, I just have to say you are a wealth of knowledge in this space. So I want to take a moment and thank you for your time and your presentation. What I'd like to do is open it up for questions. We do have a few moments for some Q&A. So if you have any questions for for Dr. Kaufman today, please feel free to unmute yourself. You can also raise your hand in using the reactions, or you can put your question in the chat. We'll facilitate it from there. So we'll give everybody a little bit of time to think about. There was a lot of information to process. So if you've got any questions, we can open it up. Dr. Kaufman, I do have a question. As you were talking about incorporating the other entities like the engineering department, as this focusing on social determinants of health, access, equity, what do you envision happening as that overlay of support continues to increase?
Thank you. The challenge is first knowledge that, gee, I didn't know engineering did that. Okay, so now I'm like one step ahead. Then you always work together because you're excited. You don't have to have a grant. You're just getting the ideas out there, which we did. Then it's writing a proposal to try to get to jumpstart it. And the reason is that in academic centers in particular, usually you live from grant to grant to subsidize your work. And so we're at the point of, we got all the ideas, the plans are out there. Now we're moving ahead with it. So that's one way of looking at it. The other is you can say, well, this thing is so valuable. You don't necessarily have to get a grant to do good works. And I'll give you an example. Though this isn't the Health Science Center, it's still something that was not clear to me. One of the groups that got very interested in this was pharmacists. Now, you know, I have my view of, I like going to a pharmacist, but I have a, you know, very narrow view. And what the dean of pharmacy told me, he said, you know, we are all over this. We make a huge impact on social determinants. I didn't know what he's talking about until he said, yeah, you know, the number one reason for bankruptcy in the United States is trying to pay these bills that are impossible, healthcare bills. Every pharmacist knows where to get medications, either the medicine you need or a lookalike or similar one for very inexpensive amount. You have patients now who don't have much money, who are spending huge amounts just to treat their diabetes, the cost of insulin is like, or to treat the cancer, or to treat rheumatoid arthritis. Very, very high cost. They don't know that there's a way to get it cheaper, but your pharmacists know, and they'll help you. I didn't realize that. And it's not just that you now have less you're spending on that. It frees up all those dollars for your car, your food, your other necessities, that it's like giving you a huge amount of money. It's like earned income tax credits. So that is not a grant to do something else. It's knowledge about what they are already doing that we didn't understand, and therefore we're working together. The other is political. Look at the president of UNM. She has two things she said she wants to push. And, you know, you got it when your president said, you said, well, you want to look good, right? You want to do well, you know, be a, you know, first in your class, you know, for whatever she's into. So one of them is she wants to be the university for New Mexico, not just the University of New Mexico. He wants to make sure this university is seen as of huge value to the whole state. No longer should it be the University of Albuquerque, Florida. The second is she wants to make sure that we are one university. We are collaborating and we are working together. When you have that kind of vision, people will work together, whether or not they get a grant, or maybe they'll get a grant later. In other words, those are three areas that sustain change, either getting a grant or working together, you know, because it's the good thing to do. And you can train your coming generations to work in a collaborative way. So that's a really important question. That's how I would answer it.
Great, great. Thank you. Let me ask you this. I've got a number of questions, but I'm going to piggyback on two. Is UNM, are you training CHWs outside of UNM? And that ties into, you know, if you're outside of central New Mexico, how does one identify if there are community health workers in their county? Do you recommend these services to primary care providers? So I think really the question is around community health workers.
Right. Okay. So there's maybe about 1,000 in the state. 1,000. It's increased, but it's about 1,000, and they're all over the state. We and others, not just the university, but others, New Mexico State, worked with the Office for Community Health Workers under the Department of Health to create the certificate for community health workers. And it's voluntary, you don't have to do it, but it goes over a year, but it's done in blocks. So it's like, so that most people are working, so you can't, you know, drop work. So it's usually maybe like 3 hours on a Wednesday evening, once a week for, you know, a semester. And then there's a practical part. That certification can be given by local community colleges. It can be given by nonprofit groups, by church groups. It can be done by hospitals. In other words, it's set out. They also screen and approve different ones that cover the same area. It doesn't have to be exactly the same one, but they can approve those. So that's how it's done. And most people who have been working in the field for a long time, they were grandfathered in or grandmothered in. So there's a grandfather, grandmother in. There's those who take the certification locally. Some of it can be online. And there are those who just decide, I don't need certification, and they're employed. In the beginning, there was almost no difference whether you're certified or not. But people are beginning to realize the future probably favors certification. For example, state Medicaid is looking at community health workers being able to bill for their services. To do that, they're going to have to be certified. And then some of it will be under a professional license, and some of it will be, no, they can bill independently because they're working in the community or home visiting, where is not necessarily under the control of a doctor or a nurse practitioner.
Excellent. Perfect. Thank you. And I think that ties into a follow-up from Jen. So, how are the services paid for? Do CHWs receive funding through payer reimbursement?
So there's different ways they're paid. The way that was common, there are many of them were volunteers, and that's kind of going out. Then there are the ones that are on soft money, like there could be a grant for diabetes or a grant for hypertension or for home visiting for something. So, but the problem there was not sustainable. In other words, they were short-term grants. It may last several years and then it ends. So that was not a very stable workforce. What happened more recently is health systems, like we showed you at the University of Mexico, learned that you could, wait a minute, if you had permanently hiring this group of people in your clinics, in your hospital, you could save a lot of money, and it's sustainable. It's not limited. So that is employment for that. The other way is being paid for what you do. That's difficult. It's new, and that's how people who are peer counselors, they're like community health workers, but they usually have lived experience and they're in the behavioral health realm. They can bill for what they do. The problem there is the amount you would get from those billings is not enough to make a full salary. It's more lucrative for them to be employed. But more and more, and I see Ellen Braden is city and county contracts are looking at not having to spend that much money from the contract, because you should be able to now bill for those community health worker services. So in other words, it makes it more attractive if they can bill. Not that it's everything that will make their salary, but it will enhance their ability to get contracts, and then they have a total salary they would get.
Excellent. Excellent. Thank you. Regarding the Social Determinants of Health certificate program, when will that be ready?
So we're working feverishly on it, and the plan is that we'll be able to roll it out, and it can be online. For everyone. It can be modular. You can say, I want those 2 modules, whatever. We're not going to make money on it, and the plan is it will be ready to be accessed in the fall semester.
Okay, so that's something that we can look forward to.
Yeah.
Regina had a comment. I really like the population health lens in the last slide. I assume that from an improvement point of view, it is not unreasonable to start with one part of the population at small scale to learn how to build and staff the process so they are sustainable. So I think really the question is around sustainability.
Right. As it turns out, those elements of that whole slide that give a quick turnaround are the ones you can fund easily. As you get further and further left, it becomes more and more important and harder to fund. Several aspects of it. There's, I think it's called Rose's Theorem in public health, that you can actually get a better impact on the health of a whole community by doing smaller things for everybody than huge amounts of things for very needy small group. And this is really trying to do both. So it's often hard to get an investor to put in something that's going to be great in 20 years. The election cycle means that a legislator has to get reelected in 2 years or 4 years so that they want a quick return on investment. But real health changes take place over a long period of time. So the strategy we use is we do both. You have to give something short-term as you're slowly working on something longer. And even the long-term interventions should always have quick kills, quick turnarounds, quick successes, so people can see it. It's tricky, but that's the only way we can see doing it. Some of our most effective interventions have been over 10 or 20 years. But we have to get successes along the way to get there.
Excellent. And yeah, I agree with that. Are there any plans to incorporate Taos County into the transportation plans?
Sorry, to incorporate what?
Taos County?
Oh, so we're just looking at trying to figure out a way to, like, for example, let me frame this. We're trying to get representation with UNM, with New Mexico State, with Department of Health in every county. And then there are the social determinants we're talking about. If we could provide in every county or work on access to each of those social determinants, we always have, a hill to climb. There's always, wait a minute, yeah, you've got the food pantry, but where's the transportation to get? So we have to, well, wait a minute, if the community says that's one of their priorities, that is a motivator for us to work with the Department of Transportation, with Senior Affairs, Aging and Long-Term Services. In other words, that's our task, to work with the community to build support to get that funded. I was in, and I think coming from mostly a city, I was unaware of the severity of the problem. And I was in Lee County, we're talking, about social determinants. And I said, we've been able to help some of our seniors get Uber to get to shopping and everything. And they said, we don't have Uber here. Well, I don't think most people realize what other counties don't have. And so let's take Taos County. I mean, they have a set of terrific stuff, and they have a lot of deficit areas, depending on which part of the county you're in. So I think it's for that planning group that works with that county. For the universities, higher education, Department of Health, we have to work collaboratively under the leadership of that counties. What do they want to have as their priority? And each of the counties has a comprehensive health planning council. That's one source. Every community hospital has to do a community health needs assessment in order to get their tax exempt status. That's another day. So there's data out there per county, but we have to look at that and figure out how we all work together to respond.
You mentioned Rose's Theorem. Am I saying that correctly?
Yes.
ROSES?
I think it's Dr. Rose. And I was taught this and I never heard of it. And I had to read about it. So, oh, I see. Okay, a lot of stuff or minor stuff or a lot of, yeah. So in other words, is where do you put your investment to have the biggest impact? And the way our health system is designed is massive resources to a relatively small number of people who have massive needs. The problem there is that they may get some benefit. The needs sometimes are so high, your impact is not as much as clearing all the problems. But you have all those patients waiting who have a much larger number, who untreated, unaddressed, whose problems are unaddressed, who will become like that person. And that's where we have to put resources. And then one step back from that is, wait a minute, we have environments which we know are going to have higher violence, higher imprisonment, higher whatever, lower graduation from school. That's where the bigger, and that's where Rose's theorem goes. If you take some of those issues, which may be not as catastrophic at the time, they will have a bigger impact long-term for society. And if I've got this totally screwed up, don't let anyone else know. Just tell me privately. I think that's what the theory is.
Okay, great. Thank you. We've got time for one more question. It's in the chat. This is from Ruth. I believe some Centennial health plans incorporate transportation, behavioral health services, etc. How are these new development services being incorporated under their health plan? Will clients need to qualify under the federal poverty level?
Good question. It totally depends on, so there's two issues. One of those is each health plan is looking at the population that's enrolled in their plan, okay? Now, that's one group, but when you look at all those people who are not in any plans, the uninsured, undocumented, so that we're trying to look a little bit broader than that. If you read the new turquoise plan, it's even more progressive than the one we have now. And I think the one we have now, Medicaid, is pretty good. It's capitated, it expanded, but I was looking at some of the elements in the new plan, it's even better. So I don't know the specific answer to that question, except I would just say this. Some of the plans will help pay for transportation to a clinical service. That's certainly what happens with the VA and some of the others. What people really need is that, but they also need transportation to decrease their loneliness, to go to social activities, to go shopping, to get out of the house, to go in the daytime, because if they have a car and they're elderly and they can't see, they can't drive at night. So I would just say transportation is a big issue, and we should start with what they already have, which is good, but I think it can go much further in the new plan.
Excellent. Perfect. Dr. Kaufman, thank you again so much.
Can I make a quick comment?
Sure. Patricio, I saw your hand and then I saw it go down, so I wasn't sure.
Yeah, I didn't want to keep it up. It's great to see you, Dr. Kaufman, always doing great stuff in our community. You really are a cornerstone of all that's going on. You know, I'm a community health worker. I had a patient call me saying, you know, I'm 80 years old. My wife is in a wheelchair. I don't know how much longer I'm going to be able to transport her on my own. They live out in Tijeras. I started doing some research, come to find out there's almost no transportation to and from Tijeras. So I started turning over stones. I came to find out that the City of Albuquerque Department of Senior Affairs will actually go out there and pick her up in a wheelchair accessible van and bring her back. So oftentimes what happens is when we think there aren't options, unless we're turning over rocks and trying to research what is available, many times we think, well, it's sort of bleak, but there are ways to figure out how to utilize the transportation services that are out there that sometimes we don't know about. I also wanted to make a comment about the earned income tax credit. I have referred a couple of my patients, quite a number of them, to the earned income tax credit program at UNMH or UNM CHW program that is under Benice Valles. And I can tell you, sometimes the individuals think, well, I didn't work, so I really am not going to get any income taxes. And when we educate them and they find out, well, even if you clean somebody's yard and you made $20, you're entitled to get cash back. And I referred one individual to your program, Dr. Kaufman, and they contacted me back and said, wow, I got $3,000. So, you know, like you say, Dr. Kaufman, it puts shoes on the kids, it puts gas in the car. So really knowing how to turn over the rocks and things like that really the CHW programs are incredible. And oftentimes I get referrals from providers, doctors who say, you know, this patient can't pay their bill, or their rent is due, or they don't know how to sign up for Medicaid or Medicare. They send them to us and we help to follow through on that. So I just wanted to make those comments because I think they're all, you know, CHWs really provide a great service to providers. So thank you all for your time. Happy
Let me make
Valentine's.
just two comments on that. Thank you so much for those comments. And there's a couple lessons in your comment. The first one, there's massive ignorance of what is available. It is so confusing how anyone understands. It's like everyone needs their personal navigator. For me, I don't understand anything. My wife has to tell me what to do. So I think we need a navigator. The second is look at the power of a community health worker as the, and I must say, sometimes the community health workers, just like was said, don't know the answer. They find it out quickly. I was astounded. I had a patient with bed bugs the other day. I didn't know what to do. I said, well, patient needs a new mattress. How do I get that? And the community health worker down the aisle said, well, I'm going to get that for him. So this is extraordinary. That's how our systems should be organized. And then the other is the community health workers can let us know, here's some policy issues that have to change. Here's what we should be doing. You know, they're working with clients, which is fantastic. Now we have to get access. We need better transportation, or we need a better housing policy. Housing is a nightmare. So thank you very much for that comment. That was great.
Wonderful. Patricio, thanks so much. As mentioned, we do have our session evaluation and CEU request for you all today. It's shared on the screen. You can do the QR code. We also put a link to the Google form in the chat. Again, this will take you to the Google form. The evaluation will help us with our QI efforts and also allows you to request your CEUs. If you have any questions or issues in completing the evaluation, please email us at info@constellationnm.com. And again, if you have called in or are unable to follow the link to the QR code, please stay on. We'll be able to help you. Dr. Kaufman, again, thank you so much. Thanks again, everyone, for your attendance and participation today. Great conversation, excellent dialogue. Our next PHC meeting is coming up in March. I'll be sending out the email announcement for the upcoming meeting, so be on the lookout for that. So again, everyone, thank you so much. Dr. Kaufman, you are a wealth of knowledge. We're grateful to have you as part of this presentation today. Thank you.